So as was introduced, I'm a health services researcher. And recently I've had a particular passion for moving the evidence into policy and decision making, but I certainly didn't start out as that. Originally, I was very, very focused on generating primary research and doing primary studies, and only recently have realized that transition into evidence and policy as being crucial to anything that we're doing and the obvious endpoint in health services. And again, I want to emphasize that I'm talking about a health services research agenda, which is different, of course, than a clinical or population health research agenda, although the KT implementation, the principles I'm going to be talking about, are going to be the same. I'm particularly interested in the interface with policy and decision makers and the appropriate level of that interface, the appropriate level of policy and decision making that I'm going to explore a little bit later on. So my primary research is through the Center for Rural Health Research, and I do a lot on starting with rural maternity care and then moved on to rural surgical care and also to rural transport, which actually underscores everything that happens in a rural community. And it's been focused, although focused on maternity care, we realize that maternity care is just one cog in the wheel of primary health care in rural. So it's kind of integrated into the larger rural landscape. I started the Applied Policy Research Unit about 2 years ago because I realized that there was no formalized structure for which to perform and introduce synthesized research evidence into policy and decision making in the area of rural. There's a lot in other areas without a doubt, primary care and some other folks that have really good units that have taken this on, but there was a lack of a mechanism when we're looking at rural healthcare. So I would often have questions from decision makers or policy folks that I had relationships with saying, well, we're trying to work on this policy, what should inform it? And so it'd be a quick scramble to pull together what I knew or what I knew of the evidence. And I realized that we wanted a quickly responding mechanism to be able to meet their needs. Yesterday, basically. They can't wait 6 months or 12 months, actually. So with some startup funding, I started APRU in order to have that structure to go through, and it's going to play a little bit in the story I'm going to tell you. And then, of course, I'm really interested, particularly, again, from a rural perspective, in looking at strength of evidence and, as importantly, the applicability of evidence to the local setting. So we often rely on systematic reviews and international evidence that looks really wonderful in practice, but actually doesn't have the contextual element of saying what will work and won't work, for example, in the BC environment or whatever jurisdiction that you're applying the evidence to. And that, as we know, is a really crucial part of it. So the applicability of the local setting is something that I work really a lot on through APRO to see where we can basically gain from research done in other jurisdictions. So I want to start with an interesting place, and I want to reconsider what we mean by evidence, because as evidence-based health planning in an era of evidence-based medicine, we really rely on the notion of rigorously collected and evaluated evidence that goes through the peer review process. So I guess what we're talking about is things that, output of research is rigorous evidence, and it sheds light on the issue that we're looking at. So we're in the context, of course, of randomized controlled trials and the work that was done by Archie Cochrane to improve our understanding of the role of evidence in practice and policy. And it was a very, very strong initiative that started in the 1970s in a big way and has produced the whole field of randomized controlled trials and also evidence-based medicine, which has translated, of course, or been segued over to evidence-based health policy, which is a good thing. We have to be mindful, though, that we have a hierarchy of evidence. And the hierarchy of evidence, starting at the very top with meta-analysis and then going down with strength of evidence, is reproduced every time we do a systematic review of published research evidence and every time we rely on a systematic review of published research evidence. And I would suggest that it's a really, really important part of our suite of evidence that we might be using, but it's not all of it. So what we're doing by reinforcing the scientific evidence, which is easily measurable, of course, is missing a really important part of the evidence continuum. And that would be the stuff that might be narrative forms that are at the very bottom of the hierarchy, community experience, that's hard to identify and more importantly, hard to quantify in line with the hierarchy of knowledge, but drastically important when we're looking at some of the health services issues. And I came across this in a really big way in my work in rural because first of all, a lot of the strength of evidence isn't there. We have low numbers, low prevalence, low incidence, and not a lot of focused studies on issues that are pertinent particularly to rural because it's not a big player at the table or hasn't been in the past. I think that's changing now, however. So that's one thing. And the second thing is I came across heaps and loads of community-based voices and narratives and kind of consolidations of experiences that were incredibly valuable about what, for example, in childbirth, what women want in the communities. But it didn't figure really strongly into the evidence base, certainly not in systematic reviews deciding, for example, on the safety of low resource, no cesarean section services. So I think that's something that I've really reoriented to and that I want us all to be thinking about is reconsidering the expansive notion of evidence to include the multiple points of view, to represent as well as we can the fulsome experience of reality. So I guess that's almost my bias that I'm coming from, but I'm hoping we can think about that. And I'll give you just an example of something I've been working with. And it's been the cost of having a local maternity service, a rural maternity service, versus the cost of not having the service. So we've been able to measure the manifest costs, pretty straightforward. So the capital costs, the operating costs, all the things that we've got through MSP and other administrative data, and that's pretty straightforward and interesting. But then there's also the other costs that are more difficult to grasp, but we can still measure them through interviews with key stakeholders, through looking at documents and documentary reporting, and from looking at other consolidations of evidence that might not be through local administrative data. So travel, accommodation, food, miscellaneous, lost wages, which is a little bit more of a difficult one. And then on top of that, I'm really interested in what I'm calling the intangible costs. So how do we measure what it's like? How do we put a cost dollar or cost figure on what it's like for a mom to be separated from her community and family? And, importantly, if we're working at all with Aboriginal communities or First Nations communities, the loss of the cultural mandate to birth on traditional territory has huge consequences. How do we cost that in a way that it can fit in to our overall assessment of cost-benefit analysis of having a service? It's really, really difficult, but it's something that I'm hoping that we're all thinking about when we're looking at evidence, so it's part of the larger scheme. So that said, of course, I think some of you have probably seen the policy pie. It's one of my favorites, and it just reminds us all of the different things that actually go into making policy. And from my experience, it's been pretty accurate. Of course, some slices of it are going to play up a little bit more in some decision-making contexts than others, but at times I've seen all of these things lead to a decision, a strategic healthcare decision, which is important. And we have to remind that research accounts for a small part of it, a really important part of it, but a small part of it in the scheme of things. So this always puts a bit of a realistic framework on the role of research in policy, and I think it's an important one. So if I'm going to move to, in health services, the decision-making landscape, I've got an extra slide in here just to talk about the different parts of where we might interface with the ministry, for example, the Ministry of Health or healthcare decision-making. A lot of people ask me, if we're looking at the policy pie, how do we engage with the people that can influence the policy pie? And, one way is literally just cold calling, finding out who's responsible for what, and cold calling. And I bring this up because this chart is what I used when I was starting out a long time ago. It looked a little bit different then. But we looked at the org structure of our local Ministry of Health, and we saw that reproductive health fell under health improvement, and we literally just found the numbers and started calling people to say, this is the research we have and the evidence we have, can we talk? And that's how we slowly worked our way into knowing who the players were. And again, realizing, of course, that research evidence is just part of it. So I just want to go on to the decision-making landscape, and at the center of this is the issue around, the conceptual issue is around the problem that I'm going to look at study today, and it's the closure of rural maternity and surgical services. So that's the problem that we have at hand. What we need, the evidence we need, is best practices for sustaining these services. So we need to know about the outcomes, we need to know about the costs, and we need to know about models of care that would be useful, or if we need extra research, if there's an evidence gap and we need to consider new models of care and evaluate them, which is often the case. So, and then the policy venue for this instance would be the Ministry of Health and the health authorities in BC. And influencing factors would be other professional associations and, of course, individual practitioners. So this is kind of the conceptual framing of the issue that I want to go forward with. And I'll explain a little bit more about the players in a minute. But before I do that, I want to get to the decision-making landscape, I'll get to that in a minute. So just to explain what the context is. We've had in British Columbia and actually across Canada, we've had the closure of rural surgical maternity services that started in a precipitous way in about 2000. And there was a whole bunch of reasons for this and a whole bunch of very good reasons for it around, providers, retaining providers, a lot of people who wanted to have immediate access to 24/7 cesarean section, higher levels of care, all sorts of things. But what we found in this kind of natural health services experiment was that the closure of services and the centralization of services under the auspices of regionalized centers of excellence didn't work because we had poor maternal newborn outcomes as a result of the closure. So we looked at that from a provincial perspective, and then we also did a study that looked at it, or I should say Stefan Grzybowski did a study that looked at it on a national level last year, and it's consistent that when we close local services, maternal newborn outcomes are poor. So that's a really nice place to start from. It's a horrible health services consequence, but in terms of the evidence, it's clear that we have to do something about this because we do not want poor maternal newborn outcomes. There's also negative psychosocial consequences. And I'm citing a lot of the literature that I've been involved in, but this is internationally grounded in the experiences in the United States, in Australia, in New Zealand, and in parts of Europe, that the consequences for women leaving their communities are negative, and they're negative cultural consequences as well. And I distinguish those. I've alluded to this earlier, but I distinguish them. The cultural consequences are focusing on the Indigenous outcomes and the Indigenous social structures when we disrupt birth from the fabric of their community. So we know that's pretty consolidated in the evidence and pretty clear. It also destabilizes primary services, primary maternity care services, when you don't have maternity care services or surgical services in the community. So rural surgical services support a whole bunch of things in the ED, the emergency department, a whole bunch of trauma stuff, of intubation and things that can be done that probably won't be done if you don't have a primary surgical team. It's also more difficult to recruit and retain providers when you don't have surgical or maternity services locally. And importantly, because we, of course, approach any health services innovation from the perspective of the AAA mandate, there's no conclusive evidence regarding cost savings. So that's been one of the banners that a lot of this has been done on, is the notion that if we centralize some of the services in regional referral centers, that we'll have cost savings. And in fact, we don't, or we don't know if we do. We hypothesize that, in fact, it's the opposite, that you incur more system costs due to transport and unintended morbidities. We don't know either way, though. So that's really important. And again, it's really important when you're amassing your evidence base in a knowledge translation exercise to know where the gaps are. Because you can at least say, well, we don't know this. We have to find that out. So just to make known the extent of the closures, I have a map here that actually goes through some and not even all of the closures, because I haven't maintained it, but that have happened in British Columbia alone around rural maternity services. So all of these communities have had a closure of service within the past 10 or 15 years. And it's, again, led to some stark outcomes. So what we did is we started building the evidence base that we needed to catalog the outcomes. And we started around experience of women and their families, around the need for local maternity services. So these are just a couple of the things we did. We did a lot of work around that, and we did specific and focused stories with our Aboriginal colleagues. So these ones are in Bella Bella, Waglisla, where we looked at what it was like for the First Nations communities to leave. We had outcomes, so we had hard data on what it means if you have to travel for care. So we did just this last year the Canadian study, which was consolidating all the things we had done in BC. And then we also looked at what it was like for different providers and based on their level of service. So we looked at surgical services in a rural community. We looked at midwifery care, and expanded midwifery study. So we had quite a large evidence base with which to go forward. And it was pretty exciting because the way forward was actually very clear. It was prescribed what we needed to do to, first of all, meet the needs, the psychosocial, but also the health needs of rural women in their communities, and also ways to do it and provider models within which to do it. So that's a really good place to start from when you have in need of a knowledge translation plan and need to move policy. So the decision-making landscape that we looked at, so where to apply this evidence in BC. So GPESS stands for GPs with Enhanced Surgical Skills, which underscore maternity services. And I'm going to talk a little bit more about that later. The venue that we were looking at was, of course, the Provincial Ministry of Health, the health authorities, but also in BC we have health services delivery areas, which are consolidations of facilities in a geographic range. So we had this health services delivery areas and right down to the local hospital administrators, because they all played a significant role in deciding what level of care was going to be at the local hospital. So we wanted to hit all levels of the decision-making framework. So we had all this evidence, and we started our KT plan, which was wonderful. We did these beautiful series of policy briefs, many more than I'm showing here, which I was really excited about. The policy briefs were very well written. They were concise. They were really easy to read, and they were in demand. People wanted them. When we started sending them out, we had a lot of requests for more policy briefs. So that seemed really good. I was really happy with that as a KT output. We also did community reports. Heaps and heaps and loads of community reports that were written for either providers or participants that had participated in the research study or key stakeholders in the local communities, and doing rural research and probably doing any research, I imagine. I think that that's an imperative, that you bring back whatever you're doing to the local community, both for the chance for them to make sure you got it right, so for on-the-ground evaluation, but also to bring the evidence back that could help them in their process around planning. And then we also hosted a series of symposia. We hosted a ton, bringing people together who had, key stakeholders together, who had an interest in the topic at hand, whatever the topic was. So sitting back about 6 years ago, I was very self-satisfied with what we were accomplishing with our KT objectives in moving the issue forward, except for we were at an impasse. Nothing was happening, and services kept closing. So when we did a really hard look at what was happening, we came up with 3 reasons. First of all was the timing. Second was the lack of system framing of the problem. And the third was a lack of awareness of the larger political landscape. So the timing was looking at what was happening provincially and within the health authorities. And quite frankly, rural and maternity, let alone rural maternity, was not at the top of the agenda. So we're talking the mid-2000s. They were dealing with other really important big health services problems, and it didn't include what we were researching. So that was one thing. And it doesn't mean, by the way, that you shouldn't still be researching what you're researching. And I'm going to talk a little bit more about timing later and how to take advantage of it. But basically, at this point, we were amassing evidence, and it wasn't being fed into the system in an effective way because the system wasn't ready to take it up. The second thing was lack of a system framing of the problem. So when we started working on this, it was all about the loss of rural maternity services. And that's what I was focused on. And we had some evidence that suggested that maternity services without local cesarean section were safe. And I've been working really closely with the integration of midwives in the province and know well their capacity to attend births in low-resource environments, and believe that rural maternity care without cesarean section was a viable option. And it is. The international literature does express an overwhelming notion of the safety of such services if three things are in place. And of course, the three things are appropriate risk screening for the population. So you have the low-risk women, or women who are likely to be able to birth without any intervention in your service. You need good emergency transport should you need it. And you also need to have a supportive system for the providers. So if a provider in a remote location phones the referral center and says, I'm running into trouble, I think I have a shoulder dystocia, what should I do? The response must not be, what the heck are you doing out there? Which was by and large what the response was at the time. So we didn't have a supportive environment. What you need is the person to go, great, you're doing a great job out there, let's work through what you need right now at this moment. So the notion of the primary maternity service is safe, but it's not sustainable. So what we found was the incredible stress that mostly physicians were under, and I say mostly because they were the ones who were mostly practicing in BC. We were just integrating midwives into the maternity care environment, but the incredible stress that they expressed about being basically the safety net, if anything, or the fact that they didn't have a safety net. They were where the buck stopped. If they got into trouble in a rural, remote community, in a normal vaginal delivery, they were where it stopped. And maybe they could transport people out, but often they would be weathered in and they wouldn't be able to. So that amount of stress really led to unsustainability. So we saw a lot of people, a lot of GPs saying, I'm not doing this anymore. I'm not getting compensated financially. I don't have a net as well as I should be. I don't have a network of care or a network of like a community of practice supporting what I'm doing, and it's actually not worth it to me. What we did notice, though, was that the services that had the communities that had perinatal surgical services, so cesarean section access, were actually quite sustainable. Not only were they sustainable, their outcomes were really good. So these are communities that are probably too small for full-on obstetrical services, but they have GPs with enhanced surgical skills, so that have gone back and learned, for example, how to do cesarean section in a short course program. We know that they're actually very effective in the healthcare system, and they underscore a lot of rural care. So when we finally got it that although primary maternity care is safe without cesarean section, given those three caveats, actually it's probably not sustainable in the model we were looking at. I think it's different with midwives, but in the time we were looking at it was GPs. So we realized the intersection between surgical services and maternity care was essential. And until that time, we had actually overlooked that a little bit to our peril. Because once we made that connection, things started to fall in place. So before I go a little bit further in the KT story, I'm just going to tell you a little bit or share a little bit about who these FPESS are. So the GP or FPESS, the Enhanced Surgical Skills folks, mostly practice in Western Canada and the North. And they practice in communities that are roughly 5,000, which is quite small, but there's some that are 5,000 to about 15,000 population, because that seems to be the population size where you're going to have enough procedural volume to need local surgical services, but you're going to be too small to have specialist services. So the challenge we have with specialist services are, first of all, that's all they do. That is their day job. The GPs can go and do clinic and do primary care, and to be available to do the occasional cesarean section or the occasional appendectomy or whatever they need to do. The second thing is that in our specialist groups now, we tend to have the requirement for less on call, so you need a bigger group, for example, of general surgeons or obstetricians. They usually want call groups of 4 or 5. To have a call group of 4 or 5, you need a huge population. So they're never, ever going to be practicing in the smaller rural settings where we actually know we need local care or the outcomes aren't going to be as good. So this breed, which is not a new thing, it's new to our attention, but rural Canada has been supported by family physicians with enhanced surgical skills for eons, and they've done it very well, often in conjunction with one or two, or solo specialist or 2 specialists, where they can provide backup. Right now, the only accredited training program is in Prince Albert, Saskatchewan. We used to have a program in Grand Prairie that's been closed due to some political discussions around the appropriateness of GPs with enhanced skills. There's, in the Prince Albert training program, there's a standardized curriculum, but in the rest of Canada, we don't have a standardized curriculum. So if somebody wants to learn how to do cesarean section, they'll go and take a cesarean section mentorship with somebody. This has created problems, and they were unforeseen, but in retrospect make sense around privileging in local areas and getting support of